You are being scheduled for a total thyroidectomy because you have been diagnosed with thyroid cancer. This video also applies to you if you have had a partial thyroidectomy and now are being advised to undergo a completion thyroidectomy or complete removal of the remainder of the thyroid gland. Thyroid cancer is almost always treated with a total thyroidectomy. Oddly, most patients with thyroid nodules or growths do not have obvious symptoms in the area of the neck where the thyroid is located and have normal thyroid hormone levels. Most thyroid cancers are detected when the patient feels a nodule by touching the neck or when a physician performs a physical exam of the neck. Many thyroid cancers are also detected when another imaging study, such as a CT scan, PET scan, or a Doppler study of the carotid arteries, is performed for other reasons. Some patients, however, develop an alteration in their voice if the tumor is beginning to grow in contact with the nerves that control the vocal cords, which can lead to vocal cord paralysis. Very rarely, patients will have breathing problems because the thyroid cancer is invading the trachea. In these cases, the cancer may also cause bleeding in the airway, which the patient may notice when coughing. When a patient has been diagnosed with thyroid cancer, usually he or she will have undergone a fine needle aspiration biopsy, also known as an FNA. An FNA is performed by placing a needle into the neck to remove cells from the thyroid and test them for cancer. If an FNA has confirmed that you have thyroid cancer prior to surgery, then further analysis of the nodule in your thyroid during surgery, known as frozen section analysis, is not recommended. This means that if the cells that were examined under the microscope definitely showed cancer, then it is usually not advisable to examine the nodule or tumor again in the operating room. The report of a definitive thyroid cancer on FNA should provide your surgeon with the information that is needed to administer the appropriate treatment, which is usually a total thyroidectomy and possible administration of radioactive iodine. While in most situations the standard treatment of thyroid cancer is the removal of the entire thyroid gland, your surgeon will discuss the extent of the gland that will be removed in detail with you. In addition, your surgeon may plan to remove lymph nodes from the central compartment of the neck, located immediately adjacent to the thyroid gland. If there is already a definitive thyroid cancer diagnosis, the patient should have an ultrasound of the entire neck to find out if the cancer has spread to the lymph nodes. In circumstances where metastatic lymph nodes are detected in the lateral compartments on the side of the neck, a lateral compartment lymph node removal will likely be performed. Your surgeon will also need to discuss a number of important issues with you related to your thyroid surgery, including the type of anesthesia, general, in which you are completely asleep, or local, in which you are awake and a nerve block is used to protect you from feeling any pain. The use of a special monitored endotracheal tube, which is used to help to monitor the nerves in your neck that supply the vocal cords. The location and length of the incision on your neck. The surgical approach that will be utilized, a conventional open approach, video-assisted, or robotic. The use of drains, type of wound closure, and the type of dressing that will be placed following the procedure. Potential complications that may occur during and after surgery. Anticipated length of stay in the hospital and when to return to the office for a follow-up visit. Anticipated recovery time, including restrictions on post-operative activity, when you can return to work, and control of symptoms following the procedure. Post-operative medications and care of the scar. Anesthesia is administered just prior to surgery in order to prevent you from feeling any pain during the procedure. An anesthesiologist monitors your vital signs, such as your blood pressure and heart rate, throughout the entire surgery to ensure your safety and to preserve your good health. There are several different types of anesthesia that may be administered during thyroid surgery. General anesthesia is the most common type of anesthesia used. In general anesthesia, you will be completely asleep throughout the entire procedure. An endotracheal tube is usually placed into the windpipe or trachea through the mouth to control your breathing during surgery. The second option is local anesthesia. In local anesthesia, the patient is not completely asleep and is given a regional nerve block which numbs the tissues in the central portion of the neck. Local anesthesia allows the patient to be aware of some of the sights and sounds of the operating room. The anesthesiologist will also give the patient a sedative to help keep the patient calm during the procedure. In this type of anesthesia, patients often feel some pushing and pulling, but this is not usually painful. Your surgeon will determine and discuss with you the best approach for anesthesia for your surgery. In certain circumstances, when general anesthesia is going to be used, your surgeon may elect to use a nerve monitoring tool called a monitored endotracheal tube. As the name suggests, the tube is inserted into your trachea or windpipe. The tube has special sensors on its surface that provide information on nerve function during the operation. Specifically, an endotracheal tube will monitor the recurrent and superior laryngeal nerves and will indicate how well these nerves are working after the removal of the thyroid tissue. Your surgeon will discuss with you whether a monitored tube will be utilized in your procedure. In order for a surgeon to access the thyroid gland for surgery, it is necessary to make a horizontal incision through the skin. Generally, the incision is made in the lower central portion of the neck. When possible, your surgeon will hide the scar in a natural skin crease in your neck to help to camouflage the scar once it has matured. These incisions generally heal extremely well, and over time, the scar fades until it is almost undetectable. Most thyroid operations are performed as a conventional open procedure, meaning through a horizontal incision on the neck. However, there are a few new technological advances being utilized to perform thyroidectomy surgeries. Your surgeon will discuss the specific approach that will be used in the procedure that is to be performed. During thyroid surgery, the parathyroid glands, the 4 glands located adjacent to the thyroid gland, must be identified so that they can be protected with their blood supply. These tiny glands are very closely associated with the thyroid gland, and in the process of preserving them, their blood supply may become compromised. If this occurs and there is a drop in parathyroid hormone level, you may experience hypoparathyroidism, meaning lower parathyroid hormone production. If your surgeon recognizes that one or more of the parathyroid glands has lost their blood supply during the operation, then an attempt may be made to restore the function of the parathyroid glands by placing them into a blood-rich environment, such as in a muscle, to restore blood supply to the glands. This procedure of repositioning the parathyroid glands is known as a parathyroid autotransplantation. An autotransplanted parathyroid gland usually takes several weeks to months to begin to function. There are several different techniques used in an autotransplantation, but the most common is done by cutting the parathyroid gland into small fragments and then placing those fragments into a muscle. This muscle's blood supply can grow new blood vessels into the repositioned parathyroid gland to restore its ability to produce and secrete parathyroid hormone. In some cases, the parathyroid glands may be inadvertently removed. This can occur when the parathyroid is located within the thyroid lobe, or it is closely associated with enlarged lymph nodes that are being removed. If the parathyroid glands are not functioning properly, there will be a drop in calcium. This usually occurs if all 4 parathyroid glands are not functioning after surgery. If your surgeon is able to preserve at least one parathyroid gland with its blood supply intact, you will most likely continue to have normal calcium levels. If the parathyroid gland function is preserved after surgery and your calcium is in the normal range during the first several days after thyroid surgery, then you don't have to worry that it might drop at a later point in the future. In the event that your calcium levels drop following thyroid surgery, you will be instructed to take pills containing calcium and vitamin D. At the hospital, calcium may also be given intravenously. If symptoms of hypocalcemia develop after surgery, including tingling of your fingers and the region around your mouth, or cramping of your fingers or toes, then you should take an extra dose of calcium and call your physician. If symptoms persist despite taking calcium, then you may need to return to the hospital or a local emergency room to have a calcium blood level checked and possibly have calcium given intravenously. There are many different materials that may be used in a wound closure, including sutures, dressings, and drains. The surgeon must select the type of sutures that he or she will use to close the neck. Some sutures require removal, while others do not. Your surgeon may also decide to place a drain in your neck. The purpose of a drain is to allow the blood or tissue fluid, known as serum, to come out of the wound rather than accumulate under the tissues. Different surgeons have different approaches to the use of drains after a routine thyroid operation, but most will place a drain in the neck after a thyroid operation that is performed with a lateral compartment lymph node dissection. There are also different types of dressings or bandages, which are placed on the wound following the operation. You will receive clear instructions on how to take care of the dressing after discharge from the hospital. At that time, you will also be given instructions regarding the timing for a return visit to your surgeon's office. Recovery from thyroid surgery is usually uneventful, but there are some potential complications that can make your recovery more difficult. Some patients experience nausea and vomiting for up to 24 hours after surgery. This can be treated with medication. Most patients experience discomfort in the neck and throat for 2 or 3 days following thyroid surgery. Pain medication is used to help control these symptoms. Medication can be taken about a half an hour before each meal in order to reduce the amount of discomfort caused by swallowing for 3 days after surgery. Swelling at the surgical site is anticipated and may become worse for 5 days following the operation. It can last up to 2 weeks. This is a normal response to tissue injury in any part of the body. Swelling is often more pronounced just above the incision than below it. Keep your head elevated and use ice to reduce swelling at the surgical site for the first day or 2 following surgery. Mild oozing may occur at the surgical site postoperatively and can lead to bruising of the neck, which can last for up to 2 weeks. Discoloration of the skin, known as ecchymosis, is not a serious complication. However, that bruising can extend down to the chest due to the effects of gravity, causing bruising of the skin of the front portion of the upper chest. Most surgeons feel it is best for patients to avoid heavy exercise, bending, and lifting for 7 to 10 days after surgery. This is because exertion raises blood pressure and may cause bleeding. Postoperative hoarseness may develop due to temporary swelling of the vocal cords from the endotracheal tube. That hoarseness usually lasts for a few days and subsides. However, the persistence of hoarseness following the operation may occur if there is damage to one of the nerves that controls the vocal cords. Hoarseness usually results from injury to the recurrent laryngeal nerve. Problems controlling and changing the pitch and volume of the voice results from injury to the superior laryngeal nerve. The manipulation of the thyroid gland may lead to a temporary paralysis of each of these nerves, which can last for a few weeks after surgery. The most significant complication following the removal of the thyroid gland is the development of impaired movement of both vocal cords, known as bilateral vocal cord paralysis. This complication is exceedingly rare, but is problematic because if the vocal cords are not able to open, then you will not be able to breathe comfortably. Patients who experience this complication will usually have a normal voice, but have noisy and sometimes labored breathing. In this situation, the physician may have to place a temporary tracheostomy, or tube, in your trachea through an opening in the front of the neck in order to restore comfortable breathing while the nerves recover. If one or both vocal cords do not resume normal movement after a period of time following surgery, then further diagnostic tests will be performed to determine the likelihood of recovery. Very rarely, additional procedures may be required to restore your voice or to open up the airway after bilateral vocal cord paralysis. Another complication you may experience after thyroid surgery is hypoparathyroidism, meaning a drop in parathyroid hormone production. As stated previously, if you experience tingling of your fingers or in the region around your mouth, or cramping of your fingers or toes after a total thyroidectomy, then you may have hypoparathyroidism. This will cause a drop in calcium and can be treated by taking pills containing calcium and vitamin D. If symptoms persist despite taking replacement pills, you may need to return to the hospital. Bleeding in the surgical site is an uncommon complication following thyroid surgery. However, if it does occur, it may be life-threatening. Rapid collection of blood can cause compression of the trachea. To treat this kind of bleeding, the wound must be immediately opened in the operating room if possible. Precautions should be taken during the early postoperative period to avoid activities that require exertion, including straining during a bowel movement. If you are home and experience sudden swelling in the neck, you should be driven immediately by a family member or friend to the nearest emergency room. You should not drive to the emergency room yourself. It is uncommon for a wound to become infected after thyroid surgery. If you experience a fever and redness with swelling over the surgical site, then you should contact your surgeon and seek immediate medical attention. A rare complication can occur during surgery if the tiny lymphatic vessels that carry fluid from the gastrointestinal tract through the thyroid region are cut. This fluid is called chyle, and if it is not controlled during surgery, it can accumulate at the surgical site. If this unusual complication occurs, you may need to alter your diet for a short time and possibly even have a second operation. All scars proceed through a course of maturation. They begin as red and fade over time. However, there are certain things you can do to minimize the appearance of your scar. You should avoid direct sun exposure for 6 months following your operation. You may also purchase over-the-counter skincare products to minimize the appearance of your scar. You can ask your surgeon to recommend specific skincare brands to you. It is critical that you are able to drink liquids and take your medication before going home from the hospital. Usually patients stay 1 night in the hospital prior to discharge. When you are discharged from the hospital, you will be prescribed a dose of thyroid hormone. The dosage will be modified based on blood work results collected during the first weeks following surgery. The exact target dose of thyroid hormone will vary depending on a number of factors, including the findings on the final pathology report and whether you have any associated problems related to your heart or your bones. During the first few weeks following surgery, blood work will be done to determine whether an adjustment of the dose of your thyroid hormone replacement medication is necessary. At the time of discharge, you will receive prescriptions for pain control medications. You will also be given prescriptions for thyroid hormone, possibly calcium and vitamin D, and a stool softener. If calcium and vitamin D are prescribed, it is imperative that these medications are taken immediately after discharge from the hospital to avoid the development of symptoms related to hypoparathyroidism. If you have experienced a drop in calcium while you were in the hospital, then you will most likely be advised to have your blood calcium levels checked after the operation during the first week after your discharge from the hospital. By the time of discharge, you can resume taking your usual medications. Following surgery, it is very common for patients to experience neck stiffness that usually resolves over the course of 5 to 7 days after surgery. If a lymph node dissection on the side of the neck is performed, that stiffness may be more severe and last longer. You will not cause any harm by moving your neck after surgery. Rarely, patients will require physical therapy following a routine thyroid operation in order to regain full neck mobility. Patients often ask when they will be able to resume driving after thyroid surgery. The first criteria is that you must be off any pain medication except for Tylenol or ibuprofen. The second criteria is that you must be able to move your neck comfortably. You can anticipate that you will be able to drive safely within a few days after a routine thyroid operation. However, it is always a safe measure to test your range of motion for all of the movements that are required for driving before you go back out on the road. Your surgeon will help you determine the appropriate time to return to work after surgery. Timing depends on what type of work you do and what demands are placed upon you in the workplace. If you have further questions, your surgeon or the clinical staff will be happy to address them for you prior to your surgery.